one. Spinous process means that bump in the middle, which is very palpable, all the way down to the last thoracic. And then last 3 or 4 ribs, so these kind of floaters, it attaches in there some too. Thoracolumbar aponeurosis and posterior iliac crest. That's a lot. So let me change colors to talk to you about the thoracolumbar aponeurosis. I mentioned briefly, so for those of you who already know it or pick things up incredibly quickly, I apologize for being redundant, but most people need to hear some of these things over and over again. So an aponeurosis is a flat tendon, and in the back we have a really big giant one. And so on the diagrams, when they show like a whiter or grayer or less fibrous thing, they're showing a tendon. And when they show a really big one, they're showing an aponeurosis. So in the back, there's this really giant one. So remember how muscles attach to tendons, well, they're not all the same shape. And some of them have like a big, broad, and so I don't, believe it or not, I'm not talking about things randomly here. Let's make a massage connection. Why does this matter? You're going to feel when you work in people's low backs, and you might already have started to feel this already, that there's a like big thickness on the back, whether they have lots of adipose or not. The adipose is kind of a separate tissue. Adipose is the word for fat. In addition to fat in that area, there's a big, thick tendon. And this becomes clinically relevant because a lot of times people have muscles in the low back that need help, but you're working through this like big, thick aponeurosis. And so we'll learn kind of how to work around it for some of the muscles that need more direct attention. But why else this is clinically relevant is that for our Latissimus dorsi, which I apparently cannot change colors. I'm very talented. There we go. When you're massaging the lats, every muscle kind of has different focal areas that are easiest and or most effective to massage it. You've already seen with the pin and stretch that kind of inferior to the axilla or the armpit, that big thick area of lats is a great place to work the big bulk of it. The muscle does go huge and powerful in this whole other area, but that's a great area to focus on it. And oftentimes the origins and insertions are a great area to focus on it, which leads me to the lats. Last and probably most clinically important part of the origin is this iliac crest. So we were pointing this out just yesterday. The whole top ridge of this hip bone is just a tight and critical area to work on lots of your clients, whether they have low back pain or not. So really good area to focus. And even in tomorrow's Swedish lab, we'll show you really yummy ways to work that. Questions, comments? Yeah.
Kind of off the wall question a little bit.
Okay.
All this is composed of 2 separate parts, isn't it?
I mean, it's
not connected, isn't it?
That's a great question. It is 2 separate halves.
Okay.
The 2 halves are they do have a joint where they are attached.
So is that the SI joint?
In the back, it's the SI joint, and in the front, it's the pubic symphysis. Excuse me. Yeah.
Does it have the same stuff with the TMJ?
Is the joint?
Yes.
The ligaments that go over the joint are made of the same stuff. But inside the pubic symphysis, there's a type of cartilage between the 2. Yeah, which is more rubbery and harder. Yeah, but then the same kind of springy ligaments do cross over it.
So the TMJ is just springy, and then the pelvic comes together with cartilage also, like in...
Yes, I think you could say that. Yes, and the TMJ I mean, it has muscles crossing it too, but the springy, and it doesn't have the, it's not the same type of joint. So we're going to look at the different types of joints. A lot of our freely movable joints, like our elbows, our shoulders, our knees, all that are the same kind of joint as the TMJ. They're all called synovial joints, and they have a similar structure. Where like the bones of the head come together, or like where the pubic bones come together, is a different kind of joint. Great questions, y'all. Any others? All right, cool. So the insertion, yay, it's a lot smaller to memorize. Intertubercular groove of the humerus. Just something to point out on this diagram is a lot of times trail guide will either show like a dotted line or like kind of faded, trying to indicate like when it attaches in front. So that's what it's trying to indicate here, is that that actually wraps around the front. Some of you may geek out and get excited, or just notice that there's a twisting in this muscle. That kind of helps with the movement. And there are certain muscles we'll study that have like a twisted structure to them. All right, so let's take a look at the actions. And there's the same as the lats, the teres major, which we're going to look at next. And so I think this is pretty straightforward. When we pull powerfully from the back, what motions do you think we can do to the shoulder? Yeah, I see a lot of extension. So extension of the shoulder. And then when we're pulling between here and the middle, if we shorten that distance, what can we do? Yeah. Some of you I can't hear, but yeah. Adduct, bringing the arm together. And then medially rotate, I think you said, yeah.
No, it's just, that's, I remember saying in the textbook, about handcuff muscle.
Mm-hmm. So when you extend, adduct, and medially rotate, that's a handcuff position. So lats and teres major are also called the handcuff muscles. So any questions about their actions or anything else about the lats? All right, the teres major I think is going to be pretty easy. It's got the same actions. Were you telling me there was no picture of it here?
Mm-hmm.
It's all coming together now. Got it. So somehow teres major is not in a slide. Awesome, but I'll draw it.
But it's on page 71.
Beautiful. Ooh, I could do that too. I think I have the right equipment set up. Elizabeth, it is so weird to have you sitting there as if you're in class.
Looking at you rapt, filling my head with good knowledge.
I'm therapeutically enamored.
I do geek out on this. All right, so let's see if we do this. Awesome. And it's flipped, which is not awesome. Where's the flippy thing for Zoom? Anyone who knows how to flip my image faster than me, let me know. Thank you, thank you.
Oh,
Much better.
Oh, I know one thing with Zoom, and that's
Woo, that's your Zoom trick.
That's an important thing to know.
because it's distracting when I'm on Zoom and it's doing that stuff.
Oh, yeah,
I can't.
yeah. I know I may look like super clumsy and ridiculous up here, but it's actually hard teaching to a class in person and a remote class at the same time. I like get here early and set up all the tech, and then it doesn't appear as if I did. That's my trick. All right, so teres major I think is pretty simple here. We've all started to work with it. So we've got the exact same actions, but let's go OIA. See if I can find the drawing tool. Where did it go? Maybe not. Maybe I won't draw. All right, I will not draw. So origin is the inferior angle and lower third of the lateral border of the scapula. And, you know, you've all started palpating the lateral border of the scapula already. I've seen some of you and helped some of you, like you can use big tools with that even, like a big heavy base of your hand, even a forearm. Don't be shy there. And so that's very palpable, and it's strong for a muscle that's only about 3-4 fingers wide. And it goes up to insert on the crest of the lesser tubercle of the humerus. There's another one that's wrapping around the fronts. And cool thing to geek out about is that that's what lets it medially rotate. Yeah. So if you attach from the side, but wrap to the front, that's how when you shorten it, it can spin inward. Whoa. Because there's a whole bunch of them that attach to the back, and they're going to do the opposite. They're going to laterally rotate, but it's the wrapping around to the front that lets it medially rotate. Yeah. And you can spend some time with yourself, your classmates, and some models to play with that. That might help it, you know, go into your hands more.
That's the one that would be, what sort of pin and stretch, or type of one?
Great question. I usually pin and stretch major and minor at the same time. You know, we had focused on lats mostly so far, but when the client is face down, if their arm is off the table and you pin on that lateral border, if you alternate having them actively move their hand up towards their ear and then back towards their butt, and keep having them do the active motion, that's going to go between medial and lateral rotation, and you're going to alternately hit both of them at the same time. So you just get a lot done quickly.
I still haven't been able to do that in a stretch.
Oh.
It's just hard to find.
Yeah, no, we can definitely spend more time with it. I think that's good to notice, because I think a lot of people sometimes fool themselves that they're doing it, and it's actually a little harder than you'd think, because it's really easy to lose the muscle. So we'll spend more time with it for sure. Yeah, it's one of my favorite techniques, and I love a lot of techniques. I find one of the reasons it's one of my favorite techniques is I find that you can get a lot done with it quickly. So I would say it's efficient. Would you say it's efficient?
I would. That's exactly the word I'd use.
Is it? Wow. All right, let's see. We did the O, we did the I, and then the actions we know, right? Because they're exactly the same as the lats. Extend the shoulder, abduct the shoulder, and medially rotate the shoulder. Now, so far, we've been mostly saying shoulder, right? But just to really kind of call out its formal name, because you'll see both in Trail Guide, is when you're talking about the shoulder as a joint, you're talking about the ball and socket of the glenohumeral joint. So gleno for that glenoid fossa, humeral for humerus, so glenohumeral. Reminds me of the old electric company where they'd have the two parts of the word. They'd come together.
Oh, that's such a good show.
I do it in kinesiology. All right, so let's see if there's anything else to quickly call out about the palpation or the massage of it. Obviously, we'll spend more time in lab. I guess one thing I do want to call out, I mean, I talked about how it's actually big, strong kind of muscle, even though it doesn't look like it. I would say it's tight on almost everybody. And we will show you this in many labs, but I would strongly say that one of your biggest tricks to releasing a lot of tension in the traps and the rhomboids and that whole central area people realize they're all tight and messed up, is to really work the lateral aspect. So you can work the medial aspect because that's what they know in their mind is messed up. And so you're like psychologically meeting a need that you're getting in there, but it's working the infraspinatus, teres major, teres minor, lats, deltoid, supraspinatus, getting out there laterally, that's really going to give it a chance to let go. And that's some exciting work, let me tell you. that's what I got on that. Let me stop recording.